Hello and welcome to Nipple Radiology. In this latest video, we're going to be talking about normal variants on chest x-rays. This is something that people have asked me quite a lot, so I thought I'd do a very quick video, about 15 minutes, just going over some of the variants that I've seen over the past few weeks of reporting. So let's get straight down to it. We'll do a very quick refresher on assessing the normal chest because I think it links in quite well with the variants. So this is how I normally assess the chest. I normally sit back and just take a look at the entirety of the chest x-ray from a distance, and that gives you a good sense of how well the patient is, and then you can zoom in and make a more detailed assessment. I tend to start at the lungs, so I zigzag my way down the lungs, checking the bronchovascular markings, making sure they're normal, that there's no bronchial wall thickening, that there's no upper lobe venous divergence. We look at the cardiophrenic angles and costophrenic angles, making sure that they're sharp, making sure there's no potential consolidation or effusion there. We look at the heart size, make sure it's not enlarged, which this one isn't. We go up, we can look at the hilar. We look at the right hilar angle, make sure there's no bulkiness of the hilar, make sure we can distinguish vessels coming out of the hilar. Are they both the same density? The left hilar is more usually higher than the right. And then we make our way up over aortic knuckle and up the superior mediastinum, make sure there's no lymphadenopathy, no tumours lurking there. Then I look at the bony anatomy, so I start with the ribs and I do it in a 3-phase assessment. So I look at the anterior portion first, then the posterior, and then the lateral aspect, because things like rib fractures that are very minimally displaced can be very hard to spot. So if you look at it in 3 phases and zoom in, it makes it much easier to make a proper detailed assessment. Make sure you check the remaining bony anatomy, so the shoulders, the cervical spine, and thoracic spine if visible. And then we look at the soft tissue, so you can scan around the soft tissues. This is a female patient, so you've got the breast tissue. Make sure that they haven't had a mastectomy, because if they've had a mastectomy, that can cause the right, so say they had a mastectomy on the right side, that could cause the right lung to look more lucent because there's less tissue, soft tissue overlying it. So it's important to check if they've had any previous surgery to the soft tissues. Usually you'd see some surgical clips in the axilla regions here. And just as a final check, I like to check 3 key review areas. Up here, behind the heart, and below both hemidiaphragms. Reason being because a lot of the lung is obscured by the overlying structures, whether it be the first anterior rib and the clavicle, the heart borders, or hemidiaphragms. And what you can do is you can invert the image, and sometimes it just makes it a little bit easier to see behind. Tumours are sneaky, they like to hide. Countless ones I've seen behind the anterior first rib. So really important just to double check those areas, guys, and make sure we're not missing anything. So that's the way that I assess the chest. Obviously, you've got to take into account things like position as well. Is it a PA image or an AP image? PAs are done as standard, so they're not normally labelled. It's assumed that that's the projection that's been taken. If it's anything outside of that, so an AP projection, a portable projection, the radiographer or rad tech should be labelling it as such, so that we know exactly what's gone on. Check if there's any rotation and check on the inspiratory effort as well, because as we saw in that previous video I did, they can make a big difference on how the anatomy looks. So it's important to factor that into the assessment. Okay, so that's assessing the normal chest. Now let's look at some variants. So this first one, let's zoom right into it. We're concerned with this area here, and if we invert it, it'll make it easier for you guys to see. It'd be great if you give us some feedback on image quality, guys, because it's crystal clear on mine, but I appreciate on mobile phones, PCs, etc. It can look quite different, so let me know. But we've got this curvilinear line coming down here, and this is something known as a posterior junction line. So this is due to the apposition of the pleural surfaces of the posterior medial surfaces of the upper lobes of the lungs coming together, posterior to the esophagus but anterior to the thoracic spine, and it creates this curvilinear line down here. You can get an anterior junction line as well, which is similar principle. There is a really good article on chest lines and stripes. It's an old article, but it has been revamped with some 3D imaging, and I'll give you a link to that later in this video. It's well worth a look, guys. And that talks all about the different lines that you might see on the chest x-ray. Okay, this one. If we look here, we've got really nice heart border on this left-hand side. We can see it all the way around. But here, we're not really seeing that right heart border clearly. And we've got this triangular-shaped density here. This is a pericardial fat pad. It's grey in density, often continuous with the heart border in a triangular shape. You maintain that crisp clarity of the hemidiaphragm. So if it was lower lobe collapse consolidation, because of silhouette sign, essentially it's sat against it, you wouldn't see the hemidiaphragm contour. Can be more difficult to differentiate between pericardial fat pad and right middle lobe collapse. We can faintly see some right heart border beyond it though, which you wouldn't see with right middle lobe collapse, again because of that silhouette sign, because of the way that the middle lobe sits up against that heart border. If it collapses against it, it would completely obscure it. If there's any doubt, I've seen follow-up imaging performed in the past for fat pads. You can check with previous x-rays obviously as well to see if there's been any change there. We do have some linear atelectasis there incidentally, post-inflammatory scarring of no clinical significance. The rest of the lungs look fine. On this chest x-ray, we're only concerned with this area. And at first glance, it looks quite hazy, patchy. Possibly some early developing infection. We might consider doing a repeat chest x-ray in 6 weeks to reassess after treatment to see if it's gone. But on closer look, if you look up here, you can actually see some of that patchiness coming out beyond the chest wall. So this is in fact a hair artifact. So this is a hair plat, which is overlying the upper zone. So really important for you student radiographers, rat techs. If there's a hair plat, make sure it doesn't overlie the chest. Similar with any other external artifacts, because really easy to miss, but otherwise this patient could go on to have an unnecessary dose of radiation because we don't know what it is. They could end up having a repeat chest x-ray unnecessarily. So really important to try and get that out of the way. Or if you do an x-ray and you think, oh no, I didn't see that, at least label it or write a comment so that we know exactly what it is. Okay, so some patients may have something called dextracardia. So this is where the heart is in the opposite orientation. So it sits on the right side of the chest. The aorta is on the opposite side. It may be part of something called situs inversus, where you have all the internal organs are basically the wrong way around. So in this patient, we can see here we've got a gas bubble here below the right hemidiaphragm. So that implies that the stomach is on the opposite side. So this patient has situs inversus. You can get that with a whole host of conditions, but patients sometimes may present with just dextracardia on its own, not necessarily situs inversus. The key thing is to recognize the projection. Now this one does actually say PA standing. It doesn't normally, with a PA, it wouldn't be labeled. Unfortunately, sometimes in patients that are done portably, the machine's automatically set to PA because that's a standard projection. But sometimes you might not be able to do the patient PA. They might be too unwell. So you might have to do it front to back as opposed to back to front with the patient sat up as opposed to stood up. Now, if you forget to change that on the machine, it will do it in the incorrect orientation. So essentially the image will be flipped. So we've got to make sure when we're reviewing these x-rays that this has been done in the correct orientation, that it's not due to a processing error, that it is actually dextracardia or situs inversus that is anatomical rather than incorrect post-processing. So we've just got to make sure of that before we verify the report. If it's the first image, you can check with the radiographers. If it's one of several, you can obviously check with previous imaging to confirm. This is an azygous lobe. So this is a variant where the azygous vein doesn't migrate properly, and you can see here we've got this tadpole-like appearance in the right upper zone. It's not really a fissure in itself. All it is this is the azygous vein. It's not properly migrated, and what it's done is it's pulled lung in on itself behind it, like a tadpole's tail. So if you see this appearance, it's absolutely nothing to worry about. It's an azygous lobe, and to be honest, I don't mention them in the reports. A lot of people don't, especially when it's primary care, because it can confuse the issue. But it's worth knowing what it is so you don't confuse it with a lung nodule. Okay, so we've got this rounded opacity here. Could be a lung nodule. But if you look, it's got well-defined lateral border. Let's zoom right into it. I appreciate it might be difficult to see this, guys, so you have to bear with me. But if you look, you can see well-defined lateral border and ill-defined medial border. And that usually suggests that this is a nipple rather than a nodule. Now, you can't go on that alone. Actually, if we look over this side, we're looking to see if there's a similar shadow at the same level on the opposite side. And we're not clearly seeing that. Possibly there could be something here, but not very, very clear. So this patient would need to have a repeat chest x-ray with nipple markers in order to see whether this is a nipple or not. This patient has had nipple markers. You can see that opacity sits right in the middle. And actually, they've also got the same opacity at the same level on the opposite side within the marker. So these are two nipple shadows. If there's any doubt, very occasionally I have seen nodules which are just unfortunately positioned and end up over a marker. So they've actually had a repeat x-ray with a nipple marker, and it has fallen in this area within the marker but turned out to be a nodule still. If there is any doubt, you could do an AP and a PA with nipple markers. If you do it on expiration, the worry is that the hemidiaphragms may come up and obscure it. So the general consensus is to do an AP and PA rather than inspiration and expiration. Again, if there's still doubt, you can do CT imaging to make absolutely certain. It's better to be certain than uncertain and just leave it, and then they come back with an enlarged mass. Okay, so if we look at this, taking a nice big breath in, so quite large volume lungs. But if we see here, these ribs look quite vertical in orientation. And again, we've got a nice sharp left heart border, but we're not clearly visualizing that right heart border. Now, it's partially obscured by thoracic spine anyway, but we're not really seeing that at all. So this is a patient with Pectus excavatum. So this is a condition where the anterior part of the chest curves inwards. And the classic signs are that vertical orientation of the ribs where it's starting to curve in, and losing that right heart border due to the anatomy. There is something called Pectus carinatum, which is pigeon chest, or it looks essentially a bit more barrel-like. So it's the opposite, basically, where the anterior chest curves outwards. Not as large volume lungs. Obviously, better to assess these on the lateral projections rather than AP or PA. This one on the face fit looks absolutely fine. So you've done all your checks of the lungs and mediastinum, and you're just about to verify your report when you notice something going on up here. So this patient's got bony cervical ribs, smaller on this right side. But it's important to note these guys because they can present with symptoms. They can present with paresthesia, neck pain, shoulder pain. So although often these are picked up incidentally, it's useful to note them in the report because if they ever present with symptoms, they've got that in the report for reference. So they'll know that that patient's got bony cervical ribs. Otherwise, they'll have to probably go on to have further imaging. They might still go on to have x-rays of the shoulder or neck, but it's always worth noting them in reports so they've got it for reference. And this shows the importance of recognizing patient position. So this is an AP erect. So in other words, this patient has been x-rayed from front to back. They're in an upright position, but they are rotated to the right. And we can tell they're rotated to the right because there's foreshortening of this right clavicle as opposed to the left. These ribs are a lot longer than on the left-hand side. The heart is kind of stretched outwards because of the projection. This aorta looks unfolded because we're seeing it in a different kind of orientation. And actually, if you look under here, at first glance, it looks like there could be a hiatus hernia. We've got this soft tissue opacity that's extending over the central part of the lower mediastinum. But if we take a look down here, we can see these shadows here and here. So this is actually breast that's migrated over the central mediastinum because the patient's rotated to the right. So really important to recognize position, soft tissue anatomy and what it might be so that we're not confusing it with a hernia. And finally, we've got a patient done AP erect portable. First thing to note before anything else is we've got some free gas here below the right hemidiaphragm. We've just got a sliver of it there of lucency. This is a patient that presented following laparotomy. So this has occurred due to opening the patient up rather than a perforation. We've got just normal stomach gas here on this left-hand side. So we're looking at line placement. We've got a right central line here, and the tip of the line is within the right atrium. Should probably be here at the cavoatrial junction or at the distal SVC region. But if we look here, if we zoom in, we do see this line here coming in. So on first glance, this may look like a pneumothorax. But actually, if we zoom in, we can see that there are lung markings beyond it. So we can kind of start to pick out these little markings here, here, here. So these are actually skin folds. Really important not to confuse them with a pneumothorax because it might end up putting a drain in unnecessarily. The key thing is, of course, that with a pneumothorax, because it's air, there will be no lung markings beyond it. Whereas this, there are. So always check to make sure you can see those lung markings. And particularly for patients that are done portably, and that are AP erect, sometimes they may be slumped back in the chair, so quite prone to having these skin folds. So it's really important just to check for those and distinguish between them and pneumothoraces. Right, guys, so that was a very, very quick whistle-stop tour of some normal variants. I guess the key things to take away are to be aware of them. Make sure that you have a systematic way of checking the chest. I mean, I gave my example there, but you'll have your own way of evaluating the chest. But make sure that you check those key review areas. The main normal variants in practice, I would say, probably to be aware of are Nyiggous fissure, because you see these quite a lot. Skin folds, because you don't want to mistake those for the pneumothoraces. Have a look out for hernias or things that might simulate hernias. So we saw that example with the breast there. And look for the cervical ribs, because you're not focused on that bony anatomy. You're looking at the lungs and the heart, and it's easy to miss those things, but actually down the line, it could have some significance for the patient. So really important to check for those. And the nipple shadows probably cause the most confusion and difficulty. Do follow up with nipple markers. If there's only one single opacity on one side, always follow up with nipple markers to check it is a nipple. If there's any confusion, you can do PA and AP nipple marker views, and you can always follow up with CT if you're really not sure. There is this really good article I mentioned earlier in the video on chest lines and stripes by Albert Zhao et al., done in 2023. It's a revamp of an old article that was published some years ago that I used to refer to quite a lot in my training, but they've actually added some 3D visual guides to it. So really, really good amalgamation of some new imaging techniques with the old X-ray example. So worth a look, guys. I'll put that in the link in the description section so you can have a look. But yeah, I hope you enjoyed it. Appreciate it's only a quick video that. And I've not gone into too much detail deliberately because I wanted to keep it to 20 minutes. But if you've liked it, please give us a like. It helps the channel massively. Please subscribe if you can and share with all your colleagues. And yeah, I'll do another video soon, but I hope you're finding them useful. Take care, guys. See you soon. Bye for now.